1 month history of painful swelling beneath his left nipple. 1 month. He has had no drainage from the nipple. He has no history of recent injury. He has a MDD um, treated with SSRI for the past 3 months. He takes no other medication. He has smoked 3 to 4 times daily for 1 year and has smoked marijuana once. He's at the 75 percentile for height and weight. Vital signs normal. Physical exam shows 1 centimeter tender firm mobile mass beneath the left areola. Pubic hair and genital sexual maturity, stage 3. Okay, there is no axillary hair. Which of the following is the most likely explanation for the swelling of this patient? Breast.
Okay, gynecomastia refers to an increase in the amount of the glandular breast tissue, increase in the amount of glandular breast tissue in male during puberty. It is common during puberty. Pubertal gynecomastia is caused by disruption in the normal balance of the androgen and estrogen and is common in boys age 12 to 14. Typically during sexual maturity rating stage 3, as in this patient, the increased concentration of estrogen are due to conversion of androstenedione and testosterone to estrone and estradiol. On physical examination, gynecomastia may be tended to palpation. Lab studies will be normal. Lab studies will be normal in pubertal gynecomastia, but could be used to delineate other cause of gynecomastia. Medications such as spironolactone, ketoconazole, or anti-androgen therapy, liver cirrhosis, germ cell tumor, hypogonadism, and recreational drug use with marijuana being the most common being the most common Physiologic gynecomastia is typically self-resolved, but medical and surgical options exist for symptomatic patients, such as aromatase inhibitor liposuction. As in this patient, no such pathologic gynecomastia, and reassurance is appropriate. Okay.
You read A and B.
Yes. Adverse effect of SSRI is not likely for this patient's presentation. Generally associated SSRI are not generally associated with gynecomastia. Common adverse effect of SSRI therapy include nausea, headache, insomnia, and sexual dysfunction. Nausea, headache, insomnia, and sexual dysfunction. Okay.
Okay. Next, 47 woman comes to the physician because of a 6 month history of increasing severe low back pain. She reports that she has had episodes of low back pain during the past 2 years, but that the episodes have recently become more severe. The pain is worse when she sits for long periods of time, rises from a sitting to a standing position, or bends towards the floor. She has not had leg pain or any prior treatment. NSAID drugs provide minimal relief, and she asked if she could benefit from operation. Exam shows moderate tenderness to palpation of the midline to the level of L4, L5. Straight, less raised, whatever is negative. Peripheral pulses are normal. Neurologic exam is fine. Which of the following is the most appropriate next step in diagnosis?
Low back pain is a common condition up to 80% of lifetime occurrence. The most common cause of chronic low back pain is degenerative disc disease. The three common components of intervertebral The three common components of the intervertebral disc are cartilaginous end plate, annular fibrosis, and nuclear pulposus. In degenerative disc disease, the nutrient gradient from the cartilaginous end plate decreases with aging along with delineating water content of the nucleus pulposus, resulting in loss of the disc height. This comorbid, this, comor, this combined with repetitive axial forces can result in tears of the annulus fibrosus. The periphery of the annulus fibrosus has a sensory innervation from the sinovertebral nerve. The periphery of the annulus fibrosus has sensory innervation from the sinovertebral nerve. Presentation of degenerative disc disease is commonly includes pain that worsens with flexion and on Valsalva maneuver, coughing, sneezing. It is important to evaluate for patient. It is important to evaluate for signs of radiculopathy, including sensory deficit, deep tendon reflex, or muscle weakness. Physical examination tests to evaluate for radiculopathy includes the SLR with a positive result being reproduction of pain into the leg. Red cell symptoms in low back pain that could increase Cauda-Equina syndrome or Kunas medullary syndrome, including saddle anesthesia, bowel or bladder incontinence, and lower extremity weakness, which warrants emergent surgical evaluation. This patient has neurological examination with no focal findings, as well as chronic pain with no reported trauma. The most appropriate next step in the diagnosis in any series of lumbar spine to evaluate for degenerative change. Treatment for degenerative disc disease: NSAID, hot and compression, weight loss, activity modification, and physical therapy.
Unit C.
Yes, MRI. MRI of the lumbar spine is indicated in evaluation of acute onset neurological deterioration like myelopathy, such as Cauda-Equina or Conus medullaris syndrome. Such lesion involving the spinal cord, such patient, such lesion involving the spinal cord and or nerve root may occur from an acute compression in the lumbosacral spinal canal, often from acute disc herniation or traumatic or pathologic vertebral column fracture. This results in bilateral lower extremity weakness, abnormal deep tendon reflex, bowel and bladder dysfunction. Saddle anesthesia. X-ray is preferred initial imaging technique as seen this patient does not have neurologic deficit identified on examination. The patient may eventually require MRI to guide therapy, though this could occur following plain X-ray. Okay,
So myelopathy will be MRI,
MRI, yes.
and then and then
It is like this low back pain is due to degenerative like osteoarthritis, age
and
more
then
than 40.
so radiculopathy will also be X-ray, or would it be MRI?
Radiculopathy, I think that MRI should be the choice.
MRI. Okay. 32 man comes to follow up. He has membranous glomerulonephritis that is a remission. Examination shows no abnormality. Serum creatinine is, I guess, fine. Urinalysis shows 2 plus protein. Which of the following is most likely to delay progression of this patient renal disease?
So we
Delay.
know that for delaying progression, we need a C inhibitor. SCE inhibitor membranous glomerulonephritis membranous nephropathy is a nephrotic syndrome characterized by proteinuria more than 3 gram per day, edema, hypoalbuminemia, hypercholesterolemia due to damage to the glomerular filtration barrier. Due to damage to the glomerular filtration barrier, large proteins such as albumin are filtered into the urine, causing hypoalbuminemia. To counteract the low serum oncotic pressure caused by urine protein losses, the liver produces lipoprotein, leading to hyperlipidemia. A biopsy of the membranous nephropathy shows the diffuse thickening of the glomerular capillary wall and on immunofluorescence IgG deposition. Although the glomerular basement membrane electron microscopy also shows subepithelial deposit. Membranous nephropathy is the most common nephrotic syndrome in white adults and can be primary, idiopathic, or secondary to conditions such as SLE, autoimmune disease against phospholipase A2 receptor, chronic hepatitis infection, especially hepatitis B or C virus, pharmaceuticals such as NSI drugs or penicillin. Untreated, it may progress to CKD. The addition of AC inhibitors such as lisinopril to the patient's regimen results in decreased angiotensin II production, which causes afferent arterial dilatation. This decreases the constriction of the arterioles. This decreases the constriction of efferent arteriole and decreasing the glomerular filtration pressure and reducing hyperfiltration in the injury of the glomerulus, resulting in delayed progression of the patient's nephropathy. Okay.
Okay, next. 81 woman comes to the physician for follow-up. She has osteoporosis treated with calcium and vitamin D supplementation. Previous trials of 2 medications were not tolerated. Her mother and sister had a history of hip fractures. The patient says she would like to try another medication for prevention of hip fracture. The physician finds a recently published study evaluating the efficacy of a new drug for osteoporosis. Total of 19,916 women between the ages of 60 and 80 were enrolled in the study. All participants had osteoporosis treated with vitamin and calcium and were observed for 3 years. Participants were randomized to receive either the new drug or placebo. Results are right here. You can see it. Which of the following conclusions is the most appropriate to draw from this data?
Okay, I am reading the explanation, then you explain.
Oh, goodness. Okay.
This scenario describes a well designated a this scenario describes a well designed randomized placebo controlled clinical trial in which the result met surgical significance due to having a p-value less than 0.05. Conventionally, a p-value cutoff of 0.05 is selected to indicate a result that was unlikely to occur due to random chance. This does not however, indicate a clinical significance. This does not, however, indicate clinical significance. A clinically significant result is one that is likely to alter a clinically significant result is one that is likely to alter clinical practice and results in benefit to patient that outweigh potential risk and costs associated with the treatment. The statistically significant difference in this scenario, the statistically significant difference in this scenario only constituted a reduction in the rate of hip fracture by 2/10 of 1% compared with placebo. This is an example of a result meeting statistical significance but not clinical significance. The number needed to treat to prevent one additional negative outcome would be exceedingly high. It would both unlikely that the use of new drugs such as minimal effect on the benefit of any patient individually, or that widespread use of new drug would prevent enough hip fracture to justify its cost to the society.
I don't know. They're just saying that that the difference is not enough. Like the study, the
P-value,
people, yeah.
p-value is this p-value, isn't it not within the range? So
Mhm.
so it is statistically significant as
Yeah. Mm-hmm.
just looking at the p-value, but
Mm-hmm.
they are talking that it is not clinically significant. So what will we see for clinical significance? Is there anything, any marker, anything?
Mm-mm-mm-mm.
Got my point?
Yeah, I get
I
what
got it
you're
that it is
saying.
statistically significant just looking at the p-value, and it is within the range, the given value p-value. But
Mhm.
how we will understand that it is not clinically significant?
That's the part I don't know. Based on the explanation, they're saying that because 401 and 442 are not too different. That's what they're kind of saying on the explanation. But I mean, how do you know that? I do not know. But I think the way I thought about the question, I deleted all the other ones didn't make sense. And then I also look at you see a lot of people stop the therapy the new drug, but not that many people stop the therapy for the placebo. So I just assume, yeah, the new drug is statistically significant based on what you just said, but it seems like a lot of people cannot tolerate it because they just stop it, they discontinue the therapy. I don't know, in the middle of the what or something. So that's kind of how I would just assume that okay, it's probably significant, but not clinical, you know, or clinically good. I think that's how I thought about it, but they're saying that they compare and it's like only 2/10 of blah 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 that I don't know. I don't know how to think about it like that.
Okay.
The other word when I was confused was the when he said the result does not apply to this patient. I thought because the patient was 81 and this is 60 to 80, maybe it doesn't apply to her. But can you read D to see why it's
Yes.
not answered? Yeah.
The results of this study do not apply to this patient is incorrect. Applicability is a concept in clinical statistics that must be distinguished from generalizability. Generalizability refers to the extent to which a study population accurately reflects the target population from which it was drawn. Applicability refers to the extent to which the treatment effect observed within a study will accurately reflect the treatment effect observed in actual patients outside the study. Applicability may be affected by a variety of factors, including the degree of similarity between the study and non-study patient in terms of their baseline characteristics, demographics, clinical scenario, and treatment. This patient closely reflects the elderly. This patient closely reflects the elderly patient in the study with osteoporosis treated with calcium and vitamin D supplementation. It is therefore reasonable to expect that the study results will apply to her. I don't understand what they have said.
I don't understand either. I think they're saying general, whatever. The general one means that the study population is the same as the target population, the real population. And applicability means that um, uh, the treatment in the study is the same thing as the treatment effect in the study is the same thing as the treatment effect in the population. Oh, never mind. I think this is just something you have to delete the other question, the other answers, and then you just get to the right answer.
When I see this type of question,
Yeah, it's just yeah.
my
There is
brain,
no.
my brain starts stopping work.
There is no point of wasting your time in this. Just yeah, yeah. I think you already did enough in finding that is statistically significant. I think you did enough in finding that. Just go with
So,
that.
so what up should I feel that this is correct? I just give it
Yeah, and just keep
because
it.
because if you just leave it for doing at the very last time, I don't
Mm-mm,
give and I don't have enough time for that
mm-mm,
also,
mm-mm,
and
mm-mm.
it never got correct. So
Yeah.
I think that it is better to give at that very time.
Yeah, and then move on. And then
Yeah.
if you have time, you can come back and try to think. I mean, if you still have time, come back and try to think, okay, why is it not D? Let me see. Let me, but
Okay.
mm. Next. Oh, what is this? 2-year-old boy from Long Island, New York, admitted to the hospital because of a 2-day history of decreased ability to bear weight on his left leg. He has refused to walk for the past 12 hours. His mother reports that he has felt warm during the past 24 hours, but he has not taken his temperature. He has a 1-year history of eczema treated with emollient lotion. Immunizations are up to date. Mother has history of recurrent skin boils. The patient is crying but consolable. He's holding his left leg flexed at the knee. He's at the 50 percentile for height and weight, so it's fine. Temperature is high, pulse is high, respiration high, BP low, exam shows no swelling or redness of the knee. Requires some passive movement of the left lower extremity. There are areas of lichenification on the antecubital and popliteal fossa. Labs, hemoglobin, I believe that's normal. Leukocyte is high. Uh, wait, what am I? Oh, segmental neutrophil, I believe that's high. And bands, I believe it's high too. Lymphocyte, I believe is normal. Monocytes, I believe is high. Let me double check all of this. Yeah, neutrophil is high. Bands is high. Lymphocyte no, low. Monocytes high. Platelet, I believe that's normal. Is it normal? No, it's high. And C reactive is high. An X-ray of the left knee and hip shows no abnormality. MRI of the left lower extremity shows marrow edema of the distal femur. Blood culture is positive for microbial. Gram stain of the blood culture is shown. Administration of which of the following is the most appropriate next
What
step?
is your diagnosis?
Oh no, that looks like coca in clusters. So Staph aureus, something. Uh, is it what?
Staph aureus can cause osteomyelitis. Yes,
Oh, it's osteomyelitis. Okay, okay. I was just looking at the thing. I mean, but I know it's Staph aureus because it's gram nectar. It's coca in clusters, but I don't know. Yeah.
it's cocaine cluster. It's a
Yeah, I
grape,
think
cocaine like grape-like cluster.
grape-like clusters, and I think staph pyogenes is what coca in
Chains.
chains. Yeah, chains. Yeah.
So cocaine cluster leg infection looks like staph aureus and it is osteomyelitis.
Osteomyelitis.
So osteomyelitis, like in the MRI, they have said there is marrow edema, which
Oh,
indicates osteomyelitis also.
med marrow. Check. They have said this what?
Marrow edema in the
Edema.
MRI.
Marrow edema. Okay.
So osteomyelitis is an infection of the bone and its marrow. Typically presents typically presents acutely and subacutely or chronically from direct inoculation of hematogenous spread from the distal site. Risk factors include traumatic injury, diabetes, peripheral vascular disease, IV drug use, and the presence of prosthetic devices and indwelling hardware. In in adults, it commonly occurs through the direct spread from the tissue infection, and less commonly through the hematogenous seeding of the bacteria. Hematogenous seeding of mm, patient typically experience weight, pain, difficulty bearing weight, tenderness to palpation in the area of the affected site. Lab studies show leukocytosis, increase inflammatory marker on imaging. Osteomyelitis may show localized osseous erosive changes of the bone. Localized osseous erosive changes of the bone. This patient has fever, leukocytosis with bandidemia, increased CRP, and MRI that shows a marrow edema. Gram stain show gram-positive bacteria in cluster pattern. Gram-positive bacteria in cluster pattern consistent with methicillin-resistant Staph aureus or methicillin-susceptible Staph aureus. The pathogen is most common cause of hematogenous osteomyelitis at the patient's age. Other common bacteremia that cause osteomyelitis in children include group A Streptococcus pneumoniae, Haemophilus influenzae. Treatment of osteomyelitis involve prompt administration of broad-spectrum antibiotic. In this case, vancomycin is the initial agent of choice as it is effective against MRSA or MMSA. Once sensitive from the culture has been obtained, the antibiotic regimen can be further tailored. Antibiotic regimen can be given further tailored. Okay.
Okay. Next, 32 men comes to the physician because of a 6-month history of shortness of breath with exertion, palpitation, and generalized swelling. His pulse is high and irregular. BP is just normal. A grade 3 out of 6 holosystolic murmur and diastolic rumble are heard at the apex. An ECG shows AFib and right ventricular hypertrophy. Okay. Which of the following is the most likely cause of this finding?
Okay. Okay. It's a rheumatic mitral valve disease. Mm, Rheumatic heart disease is a complication of rheumatic fever caused by group A Streptococcus infection resulting in progressive inflammatory progressive inflammatory damage to the heart valves with fibrosis and calcification. Mitral valve commonly Mitral valve is commonly affected. It is commonly causes insufficiency in the acute phase and stenosis later in life. Rheumatic fever typically presents with joint inflammation, pancarditis, subcutaneous nodule, erythema marginatum, and Sydenham-Chorea. Mitral stenosis is the common mitral stenosis presents with diastolic murmur radiating to the axilla. If severe enough, it can result in left atrial enlargement, cardiopulmonary edema, and arrhythmia, such as atrial fibrillation and flutter. Okay, why it is? Which clue you found?
Shoot, I don't even remember that
Sorry.
one. I don't even remember. I don't even remember how I did. Oh, I think the only thing that makes sense is the is apex of physician. So it's on the apex. So you know it's not tricuspid. You know it's not ASD. You know it's not B. I think BSD is not the apex too. It's not aortic. It's not. You can eliminate all the other ones because it's not. The apex is the mitral valve, right? Or
Yes, apex is the
yeah,
mitral valve. Okay.
yeah. Apex is the mitral valve. Now I don't know why I was confused between this one. I don't know, but I think I
That
just
one
want.
is like endocarditis, viridens
Yeah,
streptococci.
yeah, I don't know why I was confused with
Atrial
that one.
fibrillation can be
No, because it wouldn't be not for endocarditis. It
yes.
wouldn't be cause yeah, it wouldn't be a cause of that. I think yeah, I think I just went to that because APES is the only thing that has mitral here. I don't know if there is another answer that you feel that may fit. I don't know.
I got the answer right, but
Mm-hmm.
I fail to understand why I choose it.
You failed to understand. But why did you? But why did you choose it though? Why did you choose that one specifically?
I feel like mitral valve most commonly affect in the rheumatic fever, like rheumatoid arthritis, and the murmur looks like mitral stenosis.
Oh, okay, then you got it. It's that.
And in mitral stenosis, there is ECG finding, but it is PR interval prolonged PR interval, not like atrial fibrillation. Another thing I like, if we think about the cause of the uh, atrial fibrillation, okay, no, still
No,
I
what?
do not found the absolute clue, like pickup point why I choose it. Okay,
And I also.
that is the problem happening to me. Like I
Mhm,
fail to find out the pickup point. Like like I have done a question today, and in in this question, like this is a URL question.
mhm,
Okay, like this patient, I tell you, you give the answer. Okay, this patient has like fever, sore throat, malaise, headache, this and that, and this patient has three new female sexual partner over the last year,
mhm,
and examination shows full
mhm,
body maculopapular rash without the
mhm,
evidence of excoriation. There is several raised gray mucosal patches seen in the mouth. There is
mhm.
cervical, axillary, inguinal, epitrochlear lymphadenopathy is present. HIV is negative. Which of the following is the most likely diagnosis? So I tell you the differential, like
Okay.
Epstein-Barr virus,
Mhm,
gonococcal virus, syphilis,
mhm.
and rickettsia. These are four differential.
I will go with syphilis
Why?
because the epitrochlear nodes It's like
Yes,
specific of syphilis.
yes,
Yeah.
this epitrochleal lymphadenopathy, yes.
Mhm. Yeah.
Because lymphadenopathy, other forms of lymphadenopathy may be present in Epstein-Barr
Mhm.
virus also. The
Mhm.
this scenario looks like initially the Epstein-Barr virus, but the epitrochleal lymphadenopathy is specific for this syphilis. So
Yeah.
that is
And
the
what
clue.
are the patches in the mouth?
Yes, yes, there is patches in the mouth. It is also another clue.
No, but what I didn't know, like syphilis causes patches in the mouth too.
Yes,
Like what are those called? Or it's just normal
they are
patches,
just called a diffuse maculopapular rash.
diffuse macular. Okay. And I also remember from that, I don't know if you can see my screen, but I remember from sketch, for some reason it stayed in my mind. The mitral stenosis has the diastolic rumble. So it's the rumble on this little girl, and it causes mitral stenosis. And it causes the enlarged left, not the ventricle, uh, left atrium.
Mitral stenosis, yes, left atrium.
And it's this one, the enlarged left atrium, that can lead to AFib. AFib is this AFib on the TV. I don't know. It just I think I also remember that one uh, from the
Atrial atrial fibrillation. If you find a patient with atrial fibrillation, there are like I remember MITHA, like
Mm-hmm,
mitral stenosis, ischemic heart disease, thyrotoxicosis, hypertension, and
mm-hmm,
lone atrial fibrillation. Like
mm-hmm,
mitha is the word. Like
mm-hmm,
if we find a case with mitral stenosis, if we
mm-hmm,
think this, sorry, if I find a case with atrial fibrillation, if
mm-hmm,
I go the differential, then these five things actually comes in my mind, and most of the
mm-hmm,
time diagnosis is done through it.
mm-hmm, mm-hmm.
Okay,
So yeah, you were the important thing is you were gonna find the right answer either way. Yeah, you were gonna get to the right. Now you wouldn't know how you got to the right answer, but yeah, you would have gotten to the right answer.
okay.
Yeah. Randomized studies conducted to compare the efficacy of an experimental procedure with that of a conventional non-operative treatment in patients with knee injury. So surgery versus no surgery. A total of 1,000 patients are enrolled. 500 patients are assigned by chance to process to undergo the procedure, and 400 undergo the procedure. 500 patients are assigned to get the treatment, and 50 only undergo the treatment. All patients are observed for 5 year. Analysis of patient outcomes is conducted based on the treatment received by the patient. Which of the following features of this study is of greatest concern?
Okay, Re- get ready for make me understand again.
Oh, Jesus.
Okay, this scenario describes 1:1 randomized control trial in which subjects undergo either conventional non-operative or experimental operative treatment. This the most obvious and the potentially concerning issue with the study design is the lack of intention is the lack of intention to treat analysis. Intention to treat analysis is the method of statistical analysis in which all subjects who are randomized within a study, all subjects who are randomized within a study are included for analysis in the treatment group to which they are originally randomized, uh, regardless of what treatment they eventually received. The differs This differs from per protocol analysis in which subjects are analyzed according to the treatment actually received. In general, excluding randomized subjects from analysis introduces biases and decrease the prognostic benefits of randomization. Intention to treat analysis is useful for preserving the integrity of randomization, for limiting the effects of certain forms of bias, particularly attrition bias that may result from that may result from patients who did not receive the treatment, who received the wrong treatment, and who stopped treatment early or dropped out from the study. In the example scenario, the two randomized group differ greatly in the number of the patient who received in the number of the patient who received the intended treatment. 400 out of 500 in the experimental group compared with 50 out of 500 conventional group. Analyzing the results of trial according to the per protocol analysis greatly increases the risk of reaching an erroneous conclusion about effectiveness and lack of effectiveness of the procedure under study.
I
Okay,
think this one makes sense, right? We had one question like before, same
yes,
thing. Mm-hmm. Yeah, this one makes sense. So I think they always try to, they want us to use the intention to treat. So add everybody, not the per protocol where you remove the people that did not receive the thing. So that's, yeah, I think that's the key here.
okay.
Does it- Yeah. Does it make sense or no? It does a little bit.
I don't know. I don't know. I don't know. I am able to deal in the exam.
You do, or you can, okay, or the other thing, you can just remove all the other answers. Like worst case scenario, just try to remove answers. Inadequate randomization, you know this is not the right answer because there it was a randomized study and those are the best ones, and they put 500 in one and 500 in the other, so there is nothing wrong here. They didn't do anything wrong. And
Yeah,
then small sample size, you know it's not the answer, it's 1000 patients, that's a big size.
size. Yes,
And then short follow-up, they follow up for 5 years,
5
that's a
years.
no, that's definitely not the right answer. And then inappropriate control group, the control group is 500 and the other group is 500, so it's 500 500, so it's not that.
Okay,
So the
okay.
only the only the only thing left will be that one. You can also do that.
Yes, that makes sense.
That makes more sense. Okay. Okay, next. Hospital Adverse Drug Reaction Review Committee has been asked, okay, to review a series of adverse medication events on the oncology department. On 4 occasions, patients inadvertently received an antibiotic instead of a chemotherapy. Okay. Interviews with nurses in the unit show that the two medication vials are similar in color, distributed in the same size container, and are placed next to each other on the card sent by the pharmacy. Which of the following measures is most appropriate to prevent this error in the future?
So this actually makes sense. Like recommend that
Yeah.
the pharmacy repackage the containers so that they are distinct from one another. Okay, next.
Yep. 67 woman comes to the physician because of 1 month history of cough, productive of blood thin sputum. During this time, she has had 1 episode of coughing up blood and decreased appetite, resulting in like 5 pound weight loss. She has smoked a pack of cigarettes for a lot. 5 years ago, she was treated for breast cancer with no metastasis to the lymph node. Exam shows no abnormality. Serum calcium, what am I? Serum calcium, I believe that's high. Checks X-ray shows 3 centimeter left upper lobe mass. CT scan of the liver and bone scan shows no abnormality. A biopsy of the lung mass is most likely to show what? Oh, that one is
Uh,
pretty.
yes,
Yeah,
like only squamous cell cancer can cause hypercalcemia
yeah, that one is
among all
pretty.
lung mass. Small cell cancer has paraneoplastic syndrome like Cushing's yet, and large cell like gynecomastia, galactorrhea, and adenocarcinoma. What is its paraneoplastic? Hypertrophic osteoarthropathy.
Which one?
Adenocarcinoma.
Does he have one? I don't think he has one.
It can cause hypertrophic osteoarthropathy as far I remember.
Oh, okay, okay. I thought it was the, okay, maybe. So it was the large cell that caused the hypertrophy. Okay.
Large cell makes everything larger, like
Large.
gynecomastia, galacturia. Gynecomastia, breast becomes larger, and galacturia is like excess, like uh, excessive lactation. That's it. And that I remember.
Yeah, but you're right. There is one that causes hypertrophic of the
Osteoarthropathy.
I
I
just talk
think that
about.
adenocarcinoma causing hypertrophic osteopathy, as far I
Mm.
remember. Do you want me to read the explanation?
No. Previously healthy 62 woman comes to the ED because two-day history of nausea and increasing abdominal pain. She vomited once 6 hours ago but has not had constipation or diarrhea. She had a partial gastrectomy for peptic ulcer 20 years ago. Current medication, multivitamin, calcium, and iron supplements, and occasional intramuscular injections of vitamin B12. Physical exam shows abdominal distension and diffuse tenderness. Labs hemoglobin, I believe, is normal. Sodium
Sodium is
is not,
normal,
oh, wait, a bit low, but not normal.
136 to 145, isn't it?
Yeah. Fluoride is normal, and bicarb is
Normal.
normal, and hemoglobin is normal, right? CT scan of the abdomen is shown. Which of the following is the most likely diagnosis? Oh, it's right here, that thing.
Is this the thing is intersusception?
Yeah, because of this thing, this little thing. You
This,
see it?
yes,
Oh,
these questions, it's very hectic.
is it?
Intersusception. Intersusception occurs when a segment of bowel telescopes into when a segment of bowel telescopes into adjacent segment, resulting in colic abdominal pain, nausea, vomiting. Colic abdominal pain, nausea, vomiting, and potential bloody and mucoid stool. Intersusception typically occurs as a result of pathologic lead point, often lymphoid hyperplasia, lymphadenopathy, Meckel's adhesion, stricture, malignancy, which acts to draw one segment of bowel into adjacent segment during peristalsis. In this patient, intersusception may be caused by post-surgical adhesion. Intersusception may be caused by post-surgical adhesion or a complication of prior gastrectomy. If the intersusception self-resolve, there may be no symptoms. If it does not resolve, traction of mesenteric vessel can result in hypoperfusion of the segment with resultant inflammation, hemorrhage, obstruction, and pain. Diagnosis is confirmed by clinical history. Diagnosis is confirmed by clinical history, physical examination, imaging, and imaging. CT scan or ultrasonography. CT scan or ultrasonography will show telescoping interposed telescoping interposed bowel segment in the longitudinal orientation, a target sign. Target sign in the transverse colon. In this patient, target sign is seen. Okay, now it makes sense. Target sign is seen with bowel telescoping within another segment of the bowel in the left upper quadrant. While treatment of intersusception in children, usually non-surgical methods such as AR or contrast edema, treatment of intersusception in adults is surgical intervention. Okay.
Can you read E?
Yes, small bowel adhesion. Mm, Small bowel adhesion are the most common cause of small bowel obstruction in in patients with in patients with a prior history of intra-abdominal surgery. Obstruction of the small bowel occurs from partial or complete blockage of the small bowel lumen and typically presents with nausea, vomiting, and abdominal pain. CT scan of the abdomen typically shows multiple air fluid level in the setting dilated small bowels in the setting of dilated small bowels, which is seen on this patient's CT scan, which is not seen on this patient's CT scan. Partial small bowel obstruction may resolve with monitoring, supportive care, bowel rest, whereas complete or complicated partial obstruction generally requires management through exploratory laparotomy. Okay,
5-year-old girl brought to the ED 20 minutes after the onset of difficulty breathing that began while she was eating a granola bar. Her pulse is high, respiration high, BP low, exam shows stridor. There are red wheals over the top half of the body. Which of the following is the most appropriate initial step in management?
okay. So it's clear cut anaphylaxis after eating granola bar. This is this the bar people taking people are told in the groups to take during the exam? Isn't it the granola bar?
The granola bar, yeah.
Yes.
I don't know. People say it gives energy. I don't even know. I tried it. I don't feel no energy after
Don't
this.
don't eat that after eating that. If anaphylaxis starts, the whole thing will be lost.
Oh.
Yes, yeah. Look at here. After eating the granola bar, there is stridor, isn't it? So
Mm-hmm.
nobody can know who is hypersensitive to which or thing.
Uh-huh.
Okay. Do you want me to read the explanation?
No, I think that's giving it.
Like anaphylaxis, epinephrine is the must.
It's the must. It's the first thing, yeah.
Yes. For urticaria, the antihistamine is the choice.
And if the patient comes and the he's already having issues breathing, you still give anaphylaxis first.
Sorry.
Like if the patient is having like respiratory issues, like
Yes. If
and
if
yeah,
the patient comes with a respiratory problem, then uh,
you still
we
give
enough
anaphylaxis.
like epinephrine.
Okay. I think epinephrine. Yeah.
And like epiglottitis goes for endotracheal intubation and
Mhm.
nebulized racemic epinephrine for where? Croup.
Group.
Yes.
Mm.
These things are complicated. Like it is easy now, but when you are dealing the question, that is very problematic. I find sometimes hard.
It is. Okay, 24 woman comes to the ED because 1 week history of weakness and palpitation. She admits that she uses laxative daily to purge herself after eating baked goods, so bulimia. During the last month, she has had to increase the dose of laxative to achieve the same effect. There is no history of vomiting. She appears well hydrated. She is BMI is fine. While supine, her pulse is 80 and blood pressure 120 over 80, so fine. While standing, her pulse is 90 and blood pressure decreases. So like orthostatic, I guess. She reports lightheadedness when she first stand up. Examination shows no other abnormalities. Which of the following is the set of laboratory findings in this patient?
So hypotension.
Let me open the lab value so you can see. So she is pooping. She's not vomiting.
After taking laxative.
Mhm.
laxative. So it is if a pooping, mm, vomiting, diarrhea. So vomiting, diarrhea is normal anaerobic metabolic acidosis, isn't it?
Diarrhea is normal. Oh, if you wanna,
Yes.
yeah, if you wanna say it like that.
Yes. We need to find out any clue to deal with the question. Like if it is diarrhea, like look at this. As she is taking laxative, so diarrhea is the common. So diarrhea, uh, in diarrhea, it can cause normal anaerobic metabolic acidosis like hard as hyperalimentation, acetazolamide, renal tubular acidosis, diabetes, saline infusion, salicylates. So these are the so normal anion gap metabolic acidosis. So mm, 7.5 is not the answer. 7.5, these two excludes. So 7.3 and 7.4 is the normal. So A and C is the option. Normal anion gap metabolic acidosis. So pH is low, bicarbonate is low, bicarbonate is low, and PCO2 is also low. So how will I exclude? Can you exclude the these two A and C? Like
I think
how?
the way
Sorry.
I'm thinking about it, I don't
Yeah.
know. I don't know if it's my tutor that told me, but you poop base and you vomit acid. So when you vomit, you're vomiting acid, and when you poop like diarrhea, you poop base. So
Poop
if
what? Again, can you tell me again?
I don't know where I heard that. I don't know if it was divine or if it's my tutor, but you poop like you do when you do diarrhea is base that's going out. So
Yes,
it's
base.
bypass that's going out. And when you vomiting, it's acid
Acid.
that's
Yes,
going
I
out.
know.
Yeah, yeah.
Okay.
So from that, here we know that she's pooping, she's not vomiting. They specifically say she has not vomit. So
Yes.
acid is not going that it's not going out.
Yes.
So I know that for me, I don't know, potassium and bicarb will be low because she's pooping base. So that's how I got the potassium will be low and the bicarb will be low. And then, so that will be the metabolic, that will lead to what you just said, the metabolic acidosis, right? So
Why
the compensation,
potassium is low?
I don't know what potassium isn't the potassium base. I don't know why in my head I don't know. But in my head, I'm just like potassium and bicarb base, and then chloride
Bicarb is
and
low in A option A too.
yeah, but potassium, you see, potassium is high in A.
Yes, potassium is high. That is
Yeah,
the only potassium is the
yeah.
differentiating factor in here.
Yeah. And then, so it will be metabolic acidosis, which is what you already got. So pH will be low. And then the compensatory metabolic acidosis will be what is it? Respiratory alkalosis.
Alkalosis.
Alkalosis. So alkalosis CO2 is low, right? Respiratory alkalosis CO2 will be low. So that will fall here. And then there is no issue with the, that's kind of how I got to the answer. I don't know.
If okay, we need to find out the hypokalemia one.
Yeah.
Then we can access. Okay, these patients lab findings show these patient lab findings show metabolic acidosis and hypokalemia. Metabolic acidosis and hypokalemia that is consistent with suspected diagnosis of bulimia nervosa. Okay, binge eating.
Mm-hmm.
So bulimia nervosa is characterized by cycles of uncontrollable eating and compensatory purging, uncompensated eating, purging behavior such as vomiting, overuse of laxative and diuretics that occur at least once a week for 3 months or more. Unlike this patient with unlike patients with anorexia nervosa, patients with bulimia nervosa typically have BMI is healthy weight range and do not experience amenorrhea. Physical examination of patients with a binge eating, purging type of anorexia nervosa or bulimia nervosa can show dental caries from gastric hydrochloric acid erosion of enamel, parotid gland swelling from salivary gland overstimulation, and uh, scars on the knuckle secondary to abrasion from the incisor when inducing vomiting. The loss of gastric hydrochloric acid through vomiting can lead to and metabolic metabolic alkalosis. Alternatively, when laxatives are overused, either metabolic alkalosis or non-analgesic metabolic acidosis can occur. Metabolic acidosis occurs commonly secondary to the loss of bicarbonate. Metabolic acidosis occurs commonly secondary to the loss of bicarbonate in the stool. Hypokalemia is common secondary to potassium wasting in the stool. Okay, hypokalemia is common is secondary to potassium wasting in the stool. Mm, mm. In severe case, in severe cases, bulimia nervosa, signs of hypokalemia, tachycardia, hypertension. In these patients, orthostatic hypotension may be present. Hypovolemia leads to increased aldosterone concentration, resulting in further potassium secretion. If potassium is involved in the membrane potential of the muscle cell, including skeletal muscle, smooth and cardiac muscle, hypokalemia typically leads to generalized weakness, muscle cramp, fatigue, palpitation, or decreased gastrointestinal motility. Treatment of bulimia nervosa is through a combined medical and psychiatric approach involves correcting fluid and electrolyte imbalance alongside the behavioral and pharmacological.
Makes sense now, right?
Yes,
Okay. Yeah, understand it better. Okay, next.
yes.
67. I always run out of time. A 67-year-old woman admitted to
Do
the
you want to take a break?
Yes,
Yes,
yes.
yes. Okay, yes.